Okay, so good evening, one and all. Okay, welcome to our skip session 8, which is an insight into the cystic lesions of the jaw via CBCT. And our speaker for today is Dr. Arishia Tabasam. Okay, she is a renowned speaker in the field of oral medicine and radiology, and she works in the Dammam University in Saudi Arabia. So she, in fact, is my batchmate also. We had done videos together at Vinayagar Missions in Dental College in Salem together, and a very enthusiastic and good academic student. She finished up videos with a gold medal. So we are fortunate to have you, Dr. Arishia, here on our platform, on the SKIP platform. So we wholeheartedly welcome you to the SKIP session 8. Next, I also welcome my colleague, Dr. Rino Rubak Soban, who has been the backbone behind the program, who has been coordinating the program all through this time. So welcome you, Dr. Rino. Last but not least, I would like to welcome all our students, our third BDS students and the final years part 1 students to this exciting session. I am definitely sure that this particular skip session will definitely enlighten you, especially it is a topic which is highly relevant. The CBCT is the future. It is the tool which is very valuable and diagnostic for as far as a clinician is concerned. So I feel this session will definitely benefit all of you. So I wholeheartedly invite Dr. Arishia to present the topic.
Thank you, Dr. Bentley, and thank you, Dr. Rino Rupak, for the invitation. And I'm very glad and very happy to be a part of your SKIP program.
Yeah, so, I would just 1 second. I would like to ask Sandra Arun to just give a brief introduction about you to the audience.
Good evening, everyone. I'm Sandra Arun. I'm a part 1 student. So we have a speaker today. Her name is Dr. Arshia. Dr. Arshia has completed her bachelor's program from Vinayagar Mission Sankaracharya Dental College, Salem in the year 2005 with honors, and later she pursued her postgraduate studies in oral medicine and radiology from Ragas Dental College, Chennai in the year 2008. She had an opportunity to work in various universities in India, Malaysia, and Saudi Arabia. She has presented her research paper at various conferences around the globe. Currently, she is a director for dental data collection and co-director for oral and maxillofacial radiology and oral diagnosis treatment planning units at Imam Abdul Rahman bin Faisal University, Kingdom of Saudi Arabia. She has published numerous research articles in various national and international indexes, journals of repute. She engages in continuous dental education programs and is also involved in student research at the university. We welcome you, ma'am, and we are honored to have you here, and we look forward to your class.
Thank you, Dr. Sandra. Thank you. And thank you, Dr. Bentley and Dr. Renu, for granting me this opportunity to be here and become a part of your program as well. So let's start, students. Are you ready? Or you are still in a holiday mood? That's a Saturday, right? Saturday night, get outs. Okay, so anyways, it's just going to be very short. And if you are actively participating, then you learn really something, okay? So I just want you to go through this survey, which I'll send you. If you have your barcode scanner, you can scan. Otherwise, just see the chat box and just click on this link. Just click on this link and it will take you to a survey so that it helps me to understand you better, okay? So these are the questions. So just answer your question so that I can let you know what exactly it is. If you are done, let me know. Share the Did you get my this thing?
Yeah, we
Yes,
got
ma'am.
it. Got it. Yeah.
The survey, are you able to answer it?
Yes, ma'am.
Okay. Screen just a minute. Okay, I'll let you know. Just a minute. Okay, just log in into the share and let me know the results. Okay, so let's start the presentation and I'll let you know what exactly is the result of the presentation. Okay, so today we are just going to go about the cystic lesions of the jaw. So the questions which were basically like, which are the most common lesions which you encounter in your clinics, the cystic lesions, and how often you encounter. So that was the basic question. And I hope you answered. So let me know the results in a while. So coming to the WHO classification. Is everything fine? Bentley?
The PPT is not to be seen. Yeah, fine. It has come up.
Yeah. Now it's visible?
Yes, it's visible now.
Okay. So basically the WHO has reclassified the cystic lesions recently. So previously there was a classification in 2005. Okay. And now in 2017, there was a recent classification. And again, they have reclassified very recently in 2022. Okay. So basically there's two major differences here, that this post-surgical ciliated cyst has been included here. That's not included in 2017 classification. And in 2017 classification, basically they were developmental cyst and odontogenic cyst. There were two categories, but basically now they have classified as these cystic lesions of the jaws, and they have not classified as anything else. So the major difference is only this cyst has been introduced over here, that is a post-surgical ciliated cyst, and there's no major classification as leading to developmental or odontogenic cyst. So you have the major cyst here, there's a radicular cyst and the gingival cyst, the dentigerous cyst, so all other cysts are included. And I wanted to tell you one major thing also, like in 2005, what happened was this odontogenic keratocyst. Okay, in 2005 it was classified as odontogenic tumor. Okay, keratogenic odontogenic tumor, but later in 2017 they reclassified it as cyst only. Okay, and 2022 also they continued the same classification as cyst. Only in 2005 it was classified as a tumor because of its behavior. Okay, is it clear until here? Okay, just a minute. Now coming to the advantages of CBCT. CBCT has various advantages. Basically, we usually take conventional radiographs, but CBCT has the edge over the conventional radiographs based on the lesional extent, okay, to see what is the extent of the lesion and to see if there are adjacent anatomical structures which are involved regarding the lesional borders, and also to see the internal structure of the lesion, whether they are septated or there are any peripheral crenations or something like that. And also to study the buccal and the palatal aspects of the teeth as well as the lesion itself, and to study as well as root resorption. Now coming to the imaging features which are suggestive of cyst pathology, you have these basic characteristics you have to define. One is the location, where exactly is the location of the lesion, and then its association, whether it is associated with the tooth or with the pericoronal aspect of the tooth. The pericoronal is something which surrounds the crown, and the apical aspect is something which surrounds the periapex of the tooth. Okay. And how is it? Whether it is an expanding lesion or whether it is thinning the cortex or the cortex is intact. So these are all features you're supposed to comment when you are commenting any cystic lesion. And coming to the borders, how are its borders, whether they are sclerotic or corticated, or whether they are well-defined or ill-defined. And if the cystic lesion is unilocular, means there are no internal septations within the lesion. Okay, so that's meaning it's a unilocular lesion. And there are no septations within the cystic lesion. And how are its effect on the adjacent structures, whether it's like they are tooth displacement or whether there is root resorption. But basically cystic lesions usually displace the tooth rather than resorb, because that's a characteristic of benign tumors. Okay. And regarding the radio density, like whether it is completely radio lucent, okay, or you can see some internal trabeculae within that, or sometimes there can be some calcifications within the cystic lesion. Okay. So any doubts? Do you like to share something else? Problems. Microsoft is trying to recover. I think it's closing one. Open is closing then and yeah, coming to the epicenters of the specific lesions of the jaws, you have various epicenters where they are characteristic. So these lesions will occur only at these points in the oral cavity or in the jaws. For example, if you take a static bone cavity, it will occur only in the mandibular border, okay, in the body of the mandible. If you take the pericoronal cyst, it's more concentrated in the around the periapical, that is the pericoronal aspect of the tooth, especially the third molars, that is the dentigerous cyst and the keratogenic, or that is the keratocyst, because previously it was classified as a tumor. And then you have this, the lower anteriors, these are the epicenters for the PCOD. It's called as periapical cemento-osseous dysplasia. When you see the traumatic bone cavity or the simple bone cyst, so its common place is in the mandibular body and the posterior mandible. When you see the ciliated cyst of the maxilla, then the maxillary sinus is the most common this thing. And this adenomatoid aorta is most commonly associated with the unerupted tooth in the anterior maxilla, and the nasopalatine duct cyst most commonly occurs in the between the two central incisors. Is it clear? Yes, you can open your mics and you can chat or you can discuss. Okay, so don't keep your mics idle. So can you comment on the unnamed picture over here? What's this, which is not named? One is named as axial and other is named as coronal. So what is the other one?
Sagittal.
Very good. So how do you say it is sagittal? Yes, very good. It's sagittal. So the axial is something, you have something like a structure. Okay, you have something like a structure, and you have done an axial slice. That means you're cutting it and you're seeing it from the top what exactly is a cross section. So that's the axial slice. Coronal is something which you are slicing, like the loaf of a bread. When you slice it, okay, so when you sleep it and you slice it, so what you see from the front is the coronal. Okay, and the sagittal is something which you, near the mid-sagittal suture, you make a half of that and you see the other half. Very good. Okay, so these are the common views which you will be able to see. So this is a reformatted panoramic view. So it's not like a conventional OPG, but because since we are used to seeing OPGs, so that's why we have in CBCT a reformatted panoramic view as well. Okay. And then you have something called as the cross sections. These cross sections are actually very useful for studying the relationship. Just switch on the distinct battery is low. Just a minute. Switch on the battery. First one. So the cross section. So the cross sections are usually made, okay, perpendicular to the arch. So they are made perpendicular to the arch. These are the common like cross sections, which the sections used to like see where exactly is the relationship to the mental foramen, okay, and also to the maxillary sinus. Usually they take these projections to just see the anatomy and to say its relationship to the maxillary sinus or to the mental foramen. And coming to this one, this is the axial slice, okay, of the maxillary alveolar ridge. So the cross sections are made here. So see, these are the cross sections. So the A is at the level of the molar, and B is at the level of the premolar, and C is at the level of the incisor. So you can see here, there are various anatomical landmarks which are marked. So this one is the inferior nasal concha. Okay, so this is the axial slice, and these are the cross sections in relation to that. Okay. So here you can see the inferior nasal concha, the inferior nasal meatus. So which is marked in green is the hard palate. Here is the zygomatic process, and here is the mandibular canal. Okay. So this is at the level of B, that means at the level of the premolar. So it is obvious at the level of the premolar, you have the mental foramen. Okay. And then you have, this is the hard palate. And this is the buccal aspect, and this is the lingual aspect. So this is just a brush up of anatomy. If you need it, we will give it. Otherwise, it's not needed. If you are well versed, then we will stop it. But here you can see at the level of the maxillary incisors, you can see here, this is the nasopalatine canal over here. And here you can see the various foramina, okay, the lingual foramina, okay. And here is at the level, this is again an axial slice at the level of the hyoid bone. So here you have the common carotid artery, that is the carotid artery, and the internal jugular vein, which is the common place here. So when you see such kind of section, then if you like suspect any calcifications, or the patient is like older than 50 years old, then you can suspect some like calcifications over here. And this one is the axial slice at the level of the lower half of the mandibular body, okay. And this one is the transverse foramina, that is the vertebral foramen, and this one is the cervical vertebrae. FOM is nothing but the floor of the mouth. And this is the mid-sagittal slice. So here you can see FS is nothing but the frontal sinus. SS is the sphenoidal. Okay, this is the sphenoidal sinus, and this is the sella turcica. And these green coded ones are the soft palate, and the yellow coded ones is the hard palate. And here you can also see the nasopharynx and the oral cavity as well. So SP is nothing but the soft palate. So these are the basic things you should know about it. And regarding the axial slice, so the axial slice at the roots of the maxillary teeth, you have the greater and the lesser palatine foramina, okay? And this is where the eustachian tube, okay, opens into the pharynx, okay? And this one is nothing but, again, MS is nothing but the maxillary sinus, and this is the hard palate. So basically you have this one, that is superior foramina. This is of the nasopalatine canal, and the maxillary sinus, and the greater and the lesser palatine foramens. Now, can you make a guess over here? So what is ZP? At the level of the maxillary sinus. So what is ZP now? Anyone can open your mics and let me know.
Zygomatic process.
Very good. And MR? Mandibular ramus. And this is the pterygoid plates. That is the medial and the lateral pterygoid plates. Okay. The INC is nothing but the inferior nasal concha. And this one is the maxillary sinus. So basic, at least these 5 or 6 anatomical landmarks you should be well versed with. Now coming to this one, this is the that is the anterior ethmoidal, that is air cells over here, and it's the sinus over here. And this is the coronal section, which usually is used to study the sinus or the osteomeatal complex. And you have the maxillary sinus over here. This is the inferior nasal concha and the middle nasal concha. And you have some ethmoidal air cells and the sinus as well. So enough of anatomical landmarks. I'm not going to bore you, but those are the basic things. So this is the most common cyst of the, I think everyone should have come like across this radicular cyst. What are the diagnostic points of this cyst? Yes, what are the diagnostic points of this cyst? First thing is it is associated with a non-vital tooth. Okay, non-vital tooth. That's the basic thing. The tooth will be discolored. Okay, and there can be a sinus opening, or it's called as a parulus inside the oral cavity. So it is necessary that you perform a vital testing. Okay, when you see such kind of lesions, vitality test is very important. And when you take a normal conventional radiograph, you will see a corticated lesion, okay, with a radiolucent, and the cortex is corticated. So basically, when it is very clear in the radiograph that this is a radicular cyst, because always it is associated with a non-vital teeth. So the patient will give you a history. It's very important to take the history, because the patient will give you a history of trauma as well. Okay. So usually, do you take for such radicular cysts, do you take CBCTs? Answer me. Yes, my dears. Please open your mics and answer. For a radicular cyst, is CBCT necessary? Because it's clear, it's damn clear on the radiograph itself that it's a radicular cyst. Is it necessary? A CBCT is an absolute yes or no? Yes, you have to be active during the session. Okay, so it's actually not necessary, but still, if you have doubts like which of the root canals or the root apices are involved, or if it's involving the maxillary molars or the premolars, then it becomes an utmost necessity. But actually, we don't take CBCTs for a normal radicular cyst, because the conventional radiograph gives a better definition rather than the CBCTs. But in unexceptional cases, like if you have such kind of you're finding out who is the culprit, then it becomes a necessity. So you can see here in the axial CT. So this is the axial CBCT, where you can see a low density halo, which is surrounding the periapex of the tooth. And here also you can see in a multi-rooted teeth, the three arrows, okay, the three arrows are pointing to the root apices, and this is a case of a rarefying osteitis. And also you can see the cortical plates, the buccal, and there's a breach in the cortical plates, the buccal and the lingual cortical plates, there is a breach over here. That means there is loss of the buccal and the labial cortical plates. Okay, so this basically both are axial CBCTs. See, as I said, when the lesion is involving the premolars, the maxillary premolars and the molars, and you see something that there is some halo inside the cystic cavity, then you have to suspect that you see there are two pointing arrows. That means there is some amount of radiolucency which is surrounding the root apices. So that means it is associated with a rarefying osteitis, and that's why there is kind of irritation to the maxillary, the mucosa of the maxillary sinus, and that's why it has caused a hyperplastic this thing. Okay, so the left axial CBCT actually shows a low density halo around the apices. Okay, and the right axial CBCT, it usually shows a rarefying osteitis. You can see here the rarefying osteitis at the apices of the molars. Okay, and then you can see that there is a mucosal thickening of the maxillary sinus. Okay, there's a mucosal thickening of the maxillary sinus. So in such cases, you require, because you want to know whether the lesion is from the maxillary sinus or from the odontogenic infection has spread into the maxillary sinus. Okay, and here also you can see a sagittal CBCT where the radicular cyst is present, and you can see that actually there is a floor of the sinus over here, and you can see that how the floor is lifted to this level, and you can see very well the corticated margin, how the floor is lifted because of the inflammation of this lesion. Okay, and you can see there is a response of the inflammatory changes within the sinus as well. Okay. Now coming to this slide, you should not be confused, because any lesion, any tooth, okay, which has a periapical radiolucency, you should not classify it as rarefying osteitis. Okay, it could be also a developing tooth. Okay, it's a follicular space. Here also the tooth is developing. So always check if the tooth, the root formation is complete and the tooth is fully erupted in the arch, and whether the root formation is complete, because these are the developing apices, and these also can mimic as radicular cyst. Okay. And there are also some set of emotions in Zoom, I guess. You can just at least click the emotions if you're not understanding or how you're feeling, so that I can read your mind as well. Okay, so here also you can see here there is a tooth which has a dental caries, and sometimes the follicular space. So this is basically the follicular space of that particular tooth. So this also can be superimposed on the periapical like rarefying osteitis, a periapical radiolucency, because this tooth is a decade. So this can also, the periapical radiolucency of this tooth can superimpose on the follicular space, and that can give you an impression that you will not know whether it's the follicular space or whether it's the periapical radiolucency. But when you can see here, there is a sclerotic border over here. So this is basically the follicular space of this tooth, and the periapical radiolucency of this tooth is this one. Okay, so these two arrows are indicating the follicular space, and there's a separate arrow which indicates to the periapical infection of this particular tooth. So don't get confused when there is some superimposition. And also you can see here, this is a well corticated cyst. Okay, that's a panoramic view which is cropped, and you can see very well the sclerotic border which is around the lesions. Whenever there's a sclerotic border on the lesion, then you can close your eyes and say that most likely it is to be a radicular cyst. And you see that the tooth has been removed, and you can see the cystic lining. So what could be the differential diagnosis in such cases? Yes? What could be the differential diagnosis? So if you see here, here also you can see a corticated lesion in the cropped, that is the reformatted panoramic view. Okay, there's a homogeneous unilocular radiolucency. And when you take, these are the cross sections which I told you before, that the cross sections, you can see that which is the culprit tooth. So the culprit tooth here is the canine, okay, on the right side, and you can see its associations. You can very well read the buccal and the labial cortices and how well they are like enlarged, and you can very well like define the extent of the lesion within the mandibular body. Okay, so next slide is this one, where you can see how the buccal cortical plate, is enlarged, and it is showing this is an association with that of the canine. So this is again a cross-sectional image, and you can see a trapezoidal structure over here. And here you can see this is the buccal cortical plate which is thinned, and this is the lingual cortical plate, and you can see some breach. I don't know why I'm getting this one. Is everyone getting this? Bentley?
Yeah, just check now, Arisha.
Yes, okay. So the buccal cortical plate is thin, whereas the lingual cortical plate, you can see a small breach over here. That means it's something like an infected cyst, and the cystic contents are just leaking through the palatal breach. Okay, so that's why sometimes they can feel some kind of an infected cyst, and sometimes a kind of salty taste also can be felt inside. So it behaves like an abscess-like, and when how it just drains inside the oral cavity. Okay, and this is one of the cases which we received in a hospital. So this was in a younger male. And you can see here there are two lesions. There are two also a radicular cyst. When you took a CBCT, then we found the culprits as the lateral incisors. Okay, you can see the apical foramina, how they are laterally placed, and these were in association with the lateral incisors. And by taking axial CT and the sagittal views, you can study how like the extent of the lesions. Okay, he was 23 years old. And in multiple sagittal cross sections, you can very well see the definition of the lesion. And you can see that how the nasal floor is still intact. Okay, the nasal floor is still intact. It has not breached the nasal floor. Yeah, I was speaking about the differential diagnosis. So who can tell me what are these? Because I have not named it, because once naming it, it's not going to be of any benefit. Yes. So this is also like a periapical radiolucency, but it's not as defined, right? It's not as defined, but this is well defined, but it lacks a cortical border. This has an endodontic treatment into it, and it shows some kind of spiky kind of bone forming. Okay, and these are the lesions which are seen in the lower anteriors, and this is the lesion which is seen after the extraction of the tooth. So let's name one by one. So what is this one likely to be? Okay, what is this? It's a periapical abscess. Okay, and this one is a periapical granuloma. So these two are like granuloma and cyst and abscesses. People say it interchangeably, but radiographically we report it as rarefying osteitis. Okay, because when you take the biopsies, sometimes they turn out to be this, or sometimes they turn out to be that. But any cystic lesion which has a sclerotic border and it is non-vital, then it is most likely to be a radicular cyst rather than a like a periapical granuloma, because the granuloma, you can see here, there's no sclerotic border. Okay, as you define in the cyst, there should be a wide border which is surrounding the lesion. There is absence of sclerotic border in a periapical granuloma. Now coming to this one, here there was a cyst, there was a cystic cavity, but it was endodontically treated. So you no longer call it as a periapical cyst or the granuloma, but you call it as a periapical scar. What do you call it as? A periapical scar, because it's something which is trying to heal by itself. There was a lesion before, but after the treatment, it is starting to like heal, and it's called as a periapical scar. Okay. And you can see like multiple cystic lesions where the epicenter is in the lower anteriors, more common in females, but these lesions will be multiple. Okay. There will be no history of trauma, and all the teeth will be vital. All the teeth will be vital. But what we read here in a periapical abscess, granuloma, and the cyst, all the teeth are non-vital. So this is the only differentiating feature. When you see a vital teeth, especially the epicenter is in the lower anteriors, and it's especially in the females, then you can directly give a diagnosis of PCOD, that is periapical cemento-osseous dysplasia. Okay, PCOD. And this one is maybe the tooth was there, okay, and the cyst was not completely enucleated. So the tooth is out, but the cystic lesion or the lining is still intact. So that's a residual cyst. Okay, is it clear? Yes, any doubts until this point of time? I just want someone to speak, please. Otherwise, I feel I am speaking to someone who is totally absent. Yes, is it clear, the differential diagnosis?
Yes,
Yes, ma'am.
Okay, so you see that all these lesions are associated with non-vital teeth, and these lesions, the tooth are vital, but they are multiple lesions, no history of trauma. And this is something which heals after endodontic treatment. It's a periapical scar. And this is something after the removal of the teeth, the dentist or someone who has failed to remove the cystic lining, it's a residual cyst. Okay. Okay, good. And this one is again another, like you will have a periapical radiolucency, but all the periapical radiolucencies you will have above this is the mandibular canal. You can see the mandibular canal. So when it is above the mandibular canal, it's most likely odontogenic lesions. But when it is below the mandibular canal, then it's most likely non-odontogenic. Okay, so this is one of such kind where you have a cystic lining like, okay, you have a cystic lining like, you can see here very clearly there's a sclerotic border and it mimics like a cyst, or you can even tell a residual cyst. But what has happened here is it's below the inferior dental canal. Okay, so you cannot tell it as a residual cyst or it's a periapical cyst. You cannot give that terminology because it's below the inferior dental canal. And this is nothing but, it's called as the Staphnase cyst because it's nothing but the submandibular salivary gland depression. So the submandibular gland, when it lodges into the mandible, it makes a small depression. And that's why there is some cortical defect over here. And that's how it is appreciated. And sometimes it has a sclerotic border. And this is the 3D CBCT, which shows this defect over here. Is it clear? So don't get confused. When the lesion is above the inferior dental canal, then it's odontogenic. When it's below the inferior dental canal, then it is non-odontogenic, likely to be a Staphnase cyst. Now coming to the inflammatory collateral cysts, these cysts are more common in the first decade of life. Okay, so this is how they behave. I'll just show you because they are more commonly centered around the erupting. Okay, they can be the erupting molars, 1, 2, 3, mostly the third, second, and the first molar. This is cropped panoramic, which shows the cyst. So always think about the first decade of life and the erupting molars. If any cyst is associated with the erupting molars, then most likely it is a paradental cyst, and it's always associated with the bifurcation area. Okay, the bifurcation. So that's why it is called as paradental cyst. And when you take an axial CBCT, you can see here how actually the root tips are supposed to be in the center, right? But you see here there is a shift in the root tips. They have moved towards the lingual aspect. So this is the buccal aspect, and this is the lingual aspect. So you see here the buccal cortical plate is thinned, and you can see here the root tips have moved towards the palatal aspect, the palatal cortical plate. Okay, and even you can see here how the palatal cusp, it shows a prominence, and how the tooth gets digging buccally. Okay, I'll show you the clinical picture. So this cusp gains prominence. That is, a palatal cusp gains the prominence, or the lingual cusp, and this cusp will dig deep into this thing. Okay, so when you see here, when you see that all the root apices are associated with the lingual cortex, and there is thinning of the cortex, and there is prominence of this. You can see here in the panoramic, there is prominence of lingual cusp, then it is most likely to be a paradental cyst. Okay, and this is the only cyst which was included by the WHO in 2022. Previously, the cyst was there, but it was not classified into any of the categories, but it came into existence in this classification. Okay, so it usually occurs in the 5th to 6th decade of life, because many of the people, they undergo sinus surgeries, and there's a famous sinus surgery called as functional endoscopic sinus surgery. Okay, it's called as FES, where they do an endoscopic sinus surgery. So when the patient gives you history of sinus surgery, and when you see a cyst in relation to that, then it is most likely to be a pseudo-ciliated cyst of the maxilla. But it's very less common, so that's why I don't want to go into the details. But just for your knowledge and the completion, we have to know about it. And coming to the nasopalatine duct cyst. Nasopalatine duct cyst, you can see here how the cyst exists between the two like incisors, and it has a heart-shaped structure. The heart-shaped structure is because of the anterior nasal spine. When you can see here how the anterior nasal spine, okay, this is the anterior nasal spine, which has given the structure a heart shape. Okay. Now you can see here in the various, this is the axial view. You can see here the lingual or the palatal cortex is breached. And here you can see here, they are small, there is a lift in the nasal floor. The nasal floor is slowly lifted. And here you can see here, there is a breach in the nasal floor itself. Okay, this is a coronal CT. This is also coronal CT. And again, in an axial CT, here you saw the palatal, the cortex was breached. But here you can see here, the buccal cortex is breached. Okay, so this is the buccal aspect. So this is the buccal cortex, which is breached over here. That means the cyst is expanding and destroying the cortices of the jaws. Now coming to dentigerous cyst, this is the most common and most important cyst. So coming to the survey, so let's see what you have done in the survey. So how often do you encounter cystic lesions? The results were like 45 said never, and 27 said seldom, and 27 said sometimes. And share the most common cystic lesions. So many have given the names as dentigerous, odontogenic cyst, periapical, and radicular cyst. And which section is this? Many have said they don't know, and some said cross-sectional, some said coronal, but actually that section which I gave you in the survey was a cross-section. And share the reasons for attending this session. So I'm happy that everyone wants to learn something new. Okay, so everyone, the one which is coded in yellow shows that they wanted to learn something new, and it was not as a part of the requirement or something like that. So I'm happy that at least you were not forced to come over here, but at least you came by yourself. That's good. Okay, so coming to the dentigerous cyst, the most common cyst, and it's the most common. So what is pericoronal radiolucency? Pericoronal radiolucency means you have a tooth like this, and which surrounds the crown of the tooth. So this is pericoronal. Periapical is something which is associated with the apex. You understand? So the cement to enamel junction, the cement to enamel. So this is a CE junction, and the CE junction is very important in classifying certain cysts. So I'll tell you 2 or 3 diagnostic points regarding that. When this, the periphery of the cyst is directly engaging the CE junction, then it is most likely to be a dentigerous cyst. Okay, it's most likely to be a dentigerous cyst. If it is extending apical to the CEJ, then this is most likely to be a AOT, that is adenomatoid odontogenic tumor. Okay, and if sometimes it can be more like this coronal, or it can be behaving like the apical. So I'll draw one more picture like this. Okay, so if it is somewhere attaching apical, or sometimes it is attaching coronal or apical to this one, then it is most likely to be a OKC. Is it clear, my diagrams? Okay, so if it is exactly on the CE junction, it is likely to be a, yes, dentigerous cyst. Okay, if it is apical, only apical, then it is likely to be a AOT, whereas OKC will behave both up and below the CE junction. Okay, so this is a CE junction. It will behave either by attaching on the top or by attaching at the bottom. Is it clear, this point? So I'll show you how exactly to go about when you see in the radiograph. So here you can see here, this is the CE junction. Okay, so this is the CE junction, and this is how it is attaching to the CE junction, and it is associated with an unerupted tooth. So this is most likely, see here, you can see the CE junction, and it's most likely associated with an unerupted tooth, most likely to be a dentigerous cyst, and the posterior mandible is its lucky place. So when you're asked to sit inside the class, some people have the lucky places at the back of the class, and some like sitting in the front, right? And some like sitting in the middle. So here its lucky place is at the back, the posterior mandible. And here you can see here the pericoronal radiolucency, which is surrounding. This is an axial slice. And here you can see in the coronal slice how the cystic lesion, okay, is enlarging both the buccal and the lingual cortical plates. And this small arrow, which is indicating, is the inferior dental canal, okay. And here you can see this is slow growing lesion. The dentigerous cyst is a very slow growing lesion. You can see here, this was the initial incidental finding, and the patient didn't undergo any treatment. Then after 4 years, so you can see that how the lesion has expanded, and it has reached up to this size after 4 years. And here you can see there's an inverted mesiodens, and you can see the buccal and the palatal cortical plates, how they are expanded, and how the lesion is infiltrating into the adjacent tooth as well as the maxillary sinus, okay. So this one is the sagittal CBCT, and this one is the axial slice. Here you can see this was our own case where we had unerupted lateral and we had an unerupted canine, okay. And later you see that this is associated with a cystic lesion, and even the lateral incisor is associated. So there were two cystic like lesions, both were dentigerous cyst. And you can see here how the lesion has encircled the tooth. So what differential diagnosis will you give to such lesions where, okay, the first diagnosis, we will give it as dentigerous cyst. What other diagnoses are there which is associated with unerupted tooth? Yes? See, if you don't answer, then I have to hold you for long. This is very important. When you have an unerupted tooth and when you have a cystic lesion around the tooth, so what are the differential diagnoses other than the dentigerous cyst you can give it? Yes, it can be an OKC, like odontogenic keratosis, because this is also associated with unerupted tooth. It could be ameloblastomas, okay? And if the patient is younger enough and if it is associated with the anterior maxilla, then you can give AOT, that is adenomatoid odontogenic tumor, okay? Or even you can give unicystic ameloblastoma, because that is also very common in the anterior, this thing. And if it is posterior, you can give these three diagnoses like dentigerous cyst, OKC, and ameloblastoma. Is it clear, at least now? No answer? Okay, so coming to the axial CBCT, this is, you can see there's an expansion of the lingual cortical plate. Okay, so this one is the axial and this is oblique coronal. Again, it shows which is the cyst is expanding lingually. And this is a 3D CBCT, which shows the cortical defect on the lingual side. So this is the unerupted tooth. And these are the root apices of the adjacent tooth. So you can see here in the 3D CBCT how exactly there is a cortical defect on the lingual aspect. Now coming to keratocyst, as I already told you, these are the cysts also associated with unerupted tooth, and they are more common in the posterior mandible. Okay, so the main feature of this one is it shows a scalloping border. It shows a scalloping border, and it has a multilocular occurrence. Okay, so you can see here, this is scalloping. Scalloping is something which will go into the root apices like that, and it will follow a fashion that's called scalloping. Okay, so that scalloping is a characteristic feature of OKC. It's not only that, I'll tell you some other differential diagnosis as well. And you can see here the cortical defects in a 3D CBCT on the lingual side of the mandible. And here you can see here again, there is this is an incidental finding in a 61-year-old female. And this was a panoramic which was taken. And when they took an axial CBCT, you can see that how the lesion expands. When you see the mandible, okay, some lesions, they expand by expansion of the cortical plates. They make, so this is the mandible. Okay, so they cause the expansion of the cortical plates. But you see here, this lesion is characteristically expanding like this inward from the anterior to posterior. So when you have this kind of expansion where it is expanding within the medullary, this thing, then it's most likely that 3 lesions you can have into your differential diagnosis. One is the OKC, that is the odontogenic keratocyst. The second one is odontogenic myxoma, okay? And the third one is simple bone cyst, okay? So all these lesions will expand anteroposteriorly. They will not cause any kind of cortical expansion as we saw in the previous cyst. They will expand anterior posterior into the body of the mandible. So these 3 lesions you have to keep in mind whenever you are thinking about this kind of expansion inside the jawbone. And here you can see how the lesion is associated with an impacted canine. It's a 15-year-old female. And here you can see the multilocularity of the lesion. You can see there are multiple lesions which are over here. And here you can like figure out the impacted canine. And you can see the scalloping border. As I said, the scalloping is a favorite characteristic of this cystic lesion. And here you can see there was an OKC. It's more common for recurrence, but basically I will tell you 2 important things about this. One is the OKCs are orthokeratinized and parakeratinized. Okay, orthokeratinized is something which behaves like an ordinary cyst and it doesn't recur, but parakeratinized is recurrence is very common. So here you can see this was diagnosed as OKC, but later it recurred after a period of 8 to 12 years, and it has extended to the anterior. See here, you can see the extensions even into the anterior. So this is a recurrence case. If there is a recurrence case, then the cyst is most likely to be a parakeratinized. Okay, parakeratinized. And this parakeratinized only they say that is associated with that nevoid basal cell nevus syndrome. Okay. This nevoid basal cell nevus syndrome has multiple OKCs. Sometimes you should suspect multiple OKCs in that patient. And the second thing is they will have other characteristics like basal cell carcinomas, okay, basal cell carcinomas and bifid ribs. So if you have other extra oral manifestations like basal cell carcinomas and bifid rib and multiple OKCs, then, and it shows a characteristic of recurrence as well, then that OKC is usually parakeratinized, because orthokeratinized, they don't recur and they behave in a very ordinary fashion because they don't like behave so wild. Okay, but the parakeratinized are responsible for their recurrence. So again, in this axial slice, you can see here how the lesion has extended, okay, into the anterior as well as the posterior aspect of the mandible. And you can see here there are multiple lesions. As I said, the nevoid basal cell syndrome, okay. So this is associated with multiple OKCs. You see here, and the age group is around the 2nd or the 3rd decade of life. You can see here in the axial CTs, there are multiple cystic lesions, both in the anterior and the left and the right mandible, as well as in the coronal CBCT in the maxilla, you can see various cystic lesions. So this, you have to check for any other extraoral manifestations like multiple basal cell carcinomas and things like that. And you have to rule out if there is a syndrome which is involved with that. And as I told you, these are the two important differential diagnoses I gave you, because this also shows the characteristic of expanding within the medullary cavity. This is odontogenic myxoma. Okay. So this is how it behaves, and it also will remain the same. But usually this odontogenic myxoma usually occurs in older age group. Okay. Older age group. Or OKCs, they usually occur in the second or third decade. Okay, and simple bone cysts, they occur in very young individuals. So here you can see here how the axial, that is in the cross sections, you can see that how the cyst is expanding within the medullary cavity, and it is not causing an expansion of the bone, the cortical expansion like that. So simple bone cyst and odontogenic myxoma should be your differential diagnosis whenever you diagnose OKCs. But again, simple bone cysts usually they're not associated with unerupted teeth, but OKC is usually associated with unerupted teeth, and that's why how you diagnose it. Now coming to the glandular odontogenic cyst. So this cyst, just for the sake of completion, because this cyst, if it occurs in the like mandibular anteriors. Okay, something like a glandular material which is turning into cystic content, and it gives a impression of a cyst. But I'll tell you one important point. I just brought the cyst into picture because I just wanted to tell you what does a soft tissue window and a bony window looks in a CBCT. Okay, so when you look into these three pictures, this one and this one looks same and this one looks different. Okay, so who can tell me which is a bony window and which is soft tissue window? Yes, please participate. Yes.
Second is a soft tissue window.
Very good. This one is a soft tissue window. So how will you give a clue? Very good. So this one is the soft tissue window and this one is a bony window. But do everyone agree with that? I'll tell you, but actually it is not. Second one is not a soft tissue window. Okay, I'll tell you, my dear, don't worry about that. See, when you say it is a soft tissue window, so see here, where is a soft tissue highlighted? In this frame or this frame? Where is the soft tissue? See, these are all soft tissues. In which frame is the soft tissue highlighted? In this one, right? Soft tissue is highlighted in the first one. Okay, the soft tissue is highlighted in the first one. So this is the soft tissue window. And in the soft tissue window, just follow two clues. The bone will look as if someone has blown a torch on the bone. Someone is blowing a torch on the bone, and see how illuminating the bone is. Okay, so you can see here the bone, how well illuminated it is. And you can see the soft tissue, it has various shades of gray around it. And it looks highlighted, but you cannot give any definition to the bone because you see that the bone looks as if someone has blown a torch into the bone. But see here, the soft tissue looks very dull compared to this picture. Okay, and here you can see the very well details of the bone. You can see the trabeculae, the internal trabeculae of the bone over here, right? You can see the internal trabeculae. When you see such minute details within the bone, then it is most likely a bone window, because you said me this is the soft tissue window, but this is actually the bone window, my dear, because you can see some minute details of the bone and you can see the trabeculae over there. So that's a bony window. Okay, but this, where you cannot see any details of the bone, then it's most likely to be a soft tissue window. And you can see that how the soft tissue appears highlighted when compared to this one. Okay, so basically I brought this to just show you what is a soft tissue and what is a bony window. And just because this is a soft tissue cyst and it's because a salivary gland cyst, so it has a capsule that's well captured. It's a soft tissue capsule, right? So the capsule is well captured in the soft tissue window. Is it clear? And this is the coronal CT, which shows the picture. These are both the axial CBCTs, which displays the bony and the soft tissue windows. Now coming to lateral periodontal cyst. So this is the classic location for the lateral periodontal cyst. And sometimes there can be multiple cystic lesions between especially the canine and the first premolar. So that's the favorite position for this lateral periodontal cyst. And a variant of the lateral periodontal cyst is this botroid, okay, botroid odontogenic cyst, where you have this multi-locularity of the lesion. You can see here how the scalloping is, and how the lesion runs from this edge to the other edge and in between the teeth as well. So this is more characteristic of a botroid odontogenic cyst, which is nothing but a variant of the lateral periodontal cyst. So this is the coronal CBCT, which shows the loculations. And this is the cross-section CBCT. This is again a coronal CBCT, and this is a 3D image, which shows very well the lateral periodontal cyst and its favorite location. Now coming to the last but the least is the calcifying odontogenic cyst. So this one is, I'll tell you how to differentiate. So as I told you, in the anterior maxilla, what are the, in the anterior maxilla, if it is associated with unerupted tooth, I told you some differential diagnosis. What are the differential diagnoses? In the anterior maxilla, if it is associated with unerupted tooth. Suppose you think there is a canine, okay? And there is a cystic lesion. So what all differential diagnosis will you give? Yes, one is the, please open your mics, please. One is DC. Now you tell me what is DC. I'm not going to tell you.
Dentigerous cyst.
Okay, dentigerous cyst. Then what is the other different diagnosis? As I told you, OKC, you can say OKCs, okay? But in the anterior maxilla, as I told you, after dentigerous cyst, directly you should go to AOT, okay? It's called as adenomatoid odontogenic tumor, especially if it associated with the anterior maxilla, okay? But in the posterior, you can give this one, dentigerous cyst, OKC, and then you can give it as ameloblastomas and things like that, okay? But depends. Now, this one, it shows some calcifications over here. You can see some calcifications in this one. You can see some patchy calcifications. And even the axial CT, you can see here in the periphery, okay, towards the posterior, you can see some calcifications here. If the cystic lesions are associated with an unerupted tooth and you see calcifications within the lesion, then again, you have some differential diagnosis. So first one is you have to give, because AOT is also associated with calcifications, okay? Number two, this one, COC, right? COC is also associated with calcifications. Then you have the Pinbox tumor, that is calcifying epithelial odontogenic tumor, okay? So that one are the various differential diagnoses. And also there is another tumor called as ameloblastic fibroma, okay? Ameloblastic fibroma, but this will occur in younger individuals. This will occur in younger individuals. And another, there is number 5 is unicystic ameloblastoma. Okay, unicystic ameloblastoma. This also occurs in younger individuals. If it occurs in older individuals with calcifications, okay, with calcifications, this ameloblastic fibroma is also calcified, but unicystic ameloblastoma is not calcified. So if it is not with calcifications, then you can directly go for unicystic ameloblastoma or AOT. But sometimes if there are calcifications, then you can give the first 3 to 4, you can give the adenomatoid odontogenic tumor because it most commonly occurs in younger individuals. Then you have the ameloblastic fibroma. This also gives rise to calcifications. Then you can come to these 2. But this is more common in COC. That's the calcifying odontogenic cyst is more common in the second or third decade of life, but not in younger individuals. Okay. And this COC is also associated mostly with odontomas or some kind of like what do you say, hematomas. So it is associated with hematomas. So here you can see here how it is associated with a canine. And you can see here, as I said, there is not a pericoronal radiolucency which is attached to the CE junction. If it is attached to the CE junction, then you can give the classification as dentigerous cyst. But you can see here how the pericoronal radiolucency is attached apical. Okay, this is apical. So, and it is with calcifications. So it's most likely to be AOT or any other tumors with calcifications, that is COC. So if it is the attachment of this pericoronal radiolucency is apical to the CE junction, then it is not likely to be a dentigerous cyst, but it is likely to be an AOT. And you can give other tumors with classification. Is it clear? So these are the references, and I hope you enjoyed the session. So there's another survey. I just want you to go through that survey. I'll just start initiating the survey. Just a minute. I don't know. I'm not able to share the screen. I actually copied the barcode, but I don't know what's the barcode. Just sharing the. Sorry. Just a minute, I'll share with you guys. I'll share it in the chat box, just a minute. Just send it in the this thing. Send in the Zoom meeting only. I have entered, gone into the Zoom meeting inside. So any doubts regarding this? Yeah, there's a barcode here. Just a minute. Yeah, just a minute. If you have a barcode scanner, just scan it. I'll just send you through the chat box. Just a minute. Yes, this survey. Is everyone there? Yes, there's a survey, my dears. If any doubts you have, you can clear it. So
Yeah,
I have
students,
just
please do the survey. And also, if you do have any queries, please you can ask them. You can ask Dr. Adisha directly, or you can put it in the chat box also.
so start. So here are the questions. So the level of your comprehension regarding your cystic lesions. So just 3 questions. And what take-home message would you like to share with your friends, or some important points which you would like to share with your friends? So just write 2 points so that I can just read out, and then we can conclude the session. Hope you enjoyed the session. And it was not boring, but I wanted something who can really speak. But really, some students have really spoken, and I really appreciate that.
Yeah, thank you very much, Dr. Adisha, for the enlightening session. Okay, I hope it was very useful for our students, especially you had taken in depth about almost all the cystic lesions of the jaws. So thank you very much. I would like to invite Dr. Vinod Rupak to propose the vote of thanks.
Okay, good evening, Dr. Adisha. Nice meeting you after so many years. I hope you remember me.
Same here. Thank you so much. Thank you for the opportunity.
Yeah.
Thank you for the opportunity as well.
In skip session 4 or 5, we had your batchmate Sarana Fardi as speaker.
Okay.
Okay. Anyway, it's my privilege to propose a vote of thanks. On behalf of Department of Public Health Dentistry, I take this opportunity to express my gratitude to our renowned speaker, Dr. Adisha, for her excellent presentation. Okay, now and I would like to thank Dr. Bentley George, Vice Principal and Head of the Department, for his constant support. Also, I express my gratitude to third years and final years, especially the coordinator, Dr. Sandra Arun. Anyway, thank you all.
Yeah, just a minute. I just like to share some the survey responses. So the level of your comprehension regarding the cystic lesions, so many have coded green. That means it improved their diagnostic skills. And the second question was, this seminar offered information that was relevant to my needs. So it was on the code of 8. And they said that on a grade of 0 to 10, everyone was like 8. And the take-home message, how diagnosis is most important. And it said like the diagnosis is most important and the clinician should have the skill of diagnosing such lesions. So some have shared their views as well. Thank you so much for the opportunity. Thank you so much, Dr. Renu Rupak. It was glad being a part of this session, and also very glad to get invited with our seniors as well.
Thank you very much, Dr. Anisha. We would like to have you as a speaker in future also. Please do accept our invitation at that point of time also. So we are winding today's session. We'll be sending you the e-certificate shortly. Okay. Thank you very much. Thank you all.
Thank you. Thank you. Thank you.